Okay, are we at the starting time? We are. Okay, thanks for joining us. I'm Tim Anderson. I'm one of the senior research analysts at Bank of America. This is a 40-minute fireside chat on current and emerging therapeutics for obesity. There's a lot of exciting stuff going on, lots of news daily, it seems like, in the obesity space. And I'm talking with some of Mass General Brigham's finest on stage. Our panelists include Dr. Caroline Apovian, to my right, who's the co-director at the Center for Weight Management and Wellness in the Division of Endocrinology, Diabetes, and Hypertension at the Brigham, and she's a professor of medicine at Harvard Medical School. She's also a founder of the American Board of Obesity Medicine. We have Dr. Furkan Burak, who's an endocrinologist leading translational immunometabolism group at Brigham, and also a researcher at the Harvard Chan School of Public Health. We have Dr. Stephen Grinspoon, who's chief of the Metabolism Unit and director of the Nutrition Obesity Research Center at MGH. And he is an endocrinologist and professor of medicine at HMS. And we have Dr. Melanie Haynes, an endocrinologist and attending physician at Mass General and assistant professor at Harvard Medical School. So I thought we'd start maybe just current practice dynamics with the currently approved products and just kind of talk through various things. So patient demand, let's just start there. Are you guys seeing patient demand accelerate, stay the same? Is it starting to decline relative to, let's say, 1 or 2 years ago as these products started to roll out and really become viral, as they say?
All right, so it depends on, I think one of the questions was also having to do with insurance coverage. So the demand keeps going up. Both of our centers, which are merged, have waiting lists that are 1 year long, meaning that if you call today for an appointment to see one of our weight management specialists, you will get an appointment 1 year from now. Both of our programs saw 12,000 visits last year, 6,000 to 9,000 new patients on the medical treatment side only. So we have a service line that is medical treatment of obesity under endocrinology, bariatric surgery, and bariatric endoscopy. The surgeons do about 1,000 procedures per year. And this is for BMIs over 40 or over 35 with sleep apnea or diabetes. Overwhelmingly, the medical treatment arm is seeing numbers of patients wanting to be seen go up, while the bariatric surgery section is seeing those numbers go down. And that is not really good because many of the patients who we're seeing for GLP-1s really need bariatric surgery. Why? Because their BMIs are in excess of 40, 50, and 60. So the demand is going up. We can talk about what insurance is doing, which is, Blue Cross Blue Shield, Massachusetts is going to deny coverage of AOMs starting January 2026. I saw a patient today who lost 80 pounds on Zepbound. She's scared. She knows she's going to gain it all back. It's a disease. Caremark is switching everybody from Zepbound to Wegovy. Mass Health only covers Zepbound, but you have to go through phentermine first. So we can talk about demand all day long. And yes, the patients are seeking these medications out, but it's we have an access problem.
Anyone else?
I think it's probably the easiest question to answer because before probably the GLP-1 era, we were kind of practicing under the shadows of surgery. So we were seeing more mild patients and the patient didn't even know why they're seeing us. So my PCP or my doctor told me I need to lose weight. And the losing weight with medication was a scare idea, and we were seeing milder BMIs, and there was a triage, actually severe patients was going to surgery. That completely changed. Now we are seeing people really with BMI 50, 60, very severe obesity patients, huge demand, thousands are waiting to be scheduled. And now the people come to us with self-referrals, and they know what they want, and they want to be treated. Now access become an issue. Another thing is like we start treating untreatable conditions like HFpEF, like MASH, like asthma, which is not treatable otherwise, or liver fibrosis and sleep apnea. So this comorbidity treatments with anti-obesity drugs also increase the demand from subspecialty referrals. I think now we are seeing a totally different practice in our clinics.
Yeah, I agree with everything. I would add a couple of things. I was mentioning to Caroline earlier, the Lancet has a new, Diabetes Commission has a new definition of obesity that just was put forth, and there is still some debate in the field as to the validity of that, but it includes a group of people who have anthropometric-only obesity, i.e. that they don't have necessarily the highest BMI, but they have high waist circumference. In this, we have a paper coming out on this. This adds 20% to the prevalence of obesity in the United States would add. And the interesting thing is that there is significant morbidity associated with that type of obesity. They do have increased cardiovascular disease and diabetes. So it really suggests that we have to think even further about the therapeutics that we're giving these people. So I think, but relating to your question, it's going to add, as people digest this new definition, it's going to add even more to this, insatiable demand, to use an interesting word, in this arena for clinicians, which Caroline and I direct these clinics. We cannot supply the number of clinicians available to treat the patients currently.
And I would hope, too, that the increasing FDA indications for GLP-1s, such as in patients with obesity and established cardiovascular disease risk or established cardiovascular disease in the case of semaglutide, or obesity and obstructive sleep apnea in the case of tirzepatide, would help other providers increase their awareness and increase their comfort level with prescribing these drugs, because as Steve and Caroline have mentioned, it can't just be obesity medicine clinics alone. And I think the other thing that I have seen too is, of course, we know that there is a lot of use of compounded GLP-1s, and also an increasing awareness of health risks with those, whether it be incorrect doses, incorrect dosing, inappropriate additives, other side effects. And I have patients coming to me saying, I was taking a compounded GLP-1 and now I'm scared, and I want to switch over to the FDA-approved medications.
So banking on what Steve just said, and Melanie and Furkan, there's a lot of demand, and we can't see we can't see the people. We don't have access to enough providers. Why? Because obesity medicine is a new field. So the pharmacotherapeutics have gone way beyond the structure of medicine right now. So pharmacotherapeutics are there, but we've got to train more obesity medicine specialists. We have fellowships now all around the country, but it's going to take time. Primary care providers are not treating obesity. And when they do, because of the demand, the patient comes and is demanding a GLP-1, primary care providers, I just spoke to one this morning, he said, we're prescribing, but they don't know how to monitor the patient for side effects. They don't know how to provide the lifestyle. Let's face it, these drugs are different for obesity than they are for diabetes. They're not like the statins. You can just give out a statin, patients, the lipids go down. But with obesity treatment, these drugs enhance what the patient can do with their cognitive, their cognitive ability to choose the right food. It helps. But if there's the education is not there, then these drugs are not going to work as well. And we know that from all of the prescriptions. There's all these, the data's out, the pharmacy data that patients on a GLP-1, most patients stop taking it in 6 to 9 months. Why is that? These are life-altering, life-changing drugs that can give you 16 to 22% body weight. Why? What is happening? What's happening is the PCP is prescribing the GLP-1, nothing else. The patient has side effects. They don't know how to titrate down, titrate up, and then the patient on Wegovy 0.25 for 6 months says, this isn't working for me, I'm going to stop it. Or the side effects are problematic. That's what's happening now.
Okay, so there's about 1,000 things we could unpack in this discussion. We'll only get to a small fraction. I wrote a report recently to our investor base, and I said that these drugs are about as much of a wonder drug as you can have with a new class of drugs from where I sit and what I've seen over the last 30 plus years. So going back to where you started on payer coverage, it's remarkable to me that these drugs do fantastic things and payers are basically shutting access. What's going to be the solution to that front? Because we know the manufacturers aren't going to give them away for free. In this report, I actually argued these actually aren't expensive when you look at net prices relative to things like Skyrizi or lots of other drugs. You have great clinical benefit. What's the solution? There's been a solution in the marketplace, partly compounders selling them at a fraction of the price. Is that the path forward?
It's interesting, you know, because basic GLP-1 works great. You know, and there's a lot of iterations on this now with tirzepatide and Maritide and all these other ones. But, you know, and drug companies like these, because each new one they can get more money, you know, with the additional new technology. But it may be that, you know, over time, the generic ones that were developed, and they don't need to be compounded, but they just become like statins, you know. And the basic one is excellent, you know, it reduces cardiovascular disease and it reduces weight. So I think while there's a kind of a race to get the leading edge to the super best one, prices will probably drop for the, you know, initial ones, and that will hopefully eventually be allowed by insurance and to be more.
That's 2031. I mean, Wegovy goes off patent in the early 2030s, so we're years out from that. Trulicity goes off patent in a few years, but that doesn't really cause.
So we probably.
But you can use there's other ones on the market that you can use.
So
as well.
liraglutide right now, Saxenda went generic, and it's $1,200
Right, that's what I'm saying.
But so no one's going to use a daily injection, liraglutide, for 6% weight loss when you can buy Wegovy and Zepbound for $500 a month, right? So that, you know, you're right, but they've got to come down. And what I think is going to happen, I don't know if I took off your steam, but or orforglipron, the first oral, is going to come out at the end of the year. And that is going to have to be, it's got to be cheaper, right? And if it can be $200 a month, then, you know, yeah, it's a Lilly drug, but suddenly the injectables are not going to be covered by insurance because they're all going to, you know, say, well, tier 1 is orforglipron. So then the prices are going to have to come down if the injectables are going to stay on the market, right? Something's got to
I
give.
would caution, now, this is my forecast.
Okay, so.
And we've published on this.
Yep.
Lilly's not going to do that, because then every payer will force a step through on the oral to the detriment of the workhorse product, which is Zepbound.
Yeah.
So I would guess, and Lilly is certainly not giving guidance on this, the oral will probably come out at a modest discount, but not a remarkable discount, partly because otherwise you're cannibalizing their injectables and other injectables in the marketplace. So I'm not sure that's the solution
So then
either.
it's not going to do anything, because it's only 10% weight loss at best, and it has more side effects than the injectables.
That's why I think the workhorse product remains tirzepatide for them.
Well, I like Wegovy too. I like semaglutide and tirzepatide.
I think it's more than what we like. Also, we know that this losing the payer came from this year of 2024, that none of the medications were available. Discontinuation rates was 75%. They were arguing that we spend a lot of money and the people stop. So I think the SELECT trial really started initial big payer coverage with cardiovascular benefit. I think once we have this continuous use of tirzepatide, Wegovy for a couple years and showing all these comorbidities also get treated, and all these cardiovascular benefits are sustained, and the people not discontinue the drug 75%, because we know that if you look at the commercial weight management centers, their discontinuation rate is less than 20% versus real world is 75%. So this is not just side effect. So if we can achieve to really empower PCPs or kind of find a way that people understand this is a chronic condition that needs to be treated long term, and then that really reflects to cost-effective outcomes, then I think the payers will also come back and say, okay, we've covered this. Because we saw this in diabetes. I mean, GLP-1s are not new to us. We utilize indefinite GLP-1s in diabetes and then start seeing less dialysis, less stent placement, less heart attacks, reversing the course, less insulin usage. So that reflected to a good outcome. So we have to achieve that in obesity as well. And now we are, I think, in a good trajectory to teach that. And then orals definitely going to increase because the small molecule manufacturing is way cheaper. So increasing access to outside US is also going to increase for sure. And then all this competition coming, it's not just orforglipron, there are many other oral drugs that are going to come in. Ribelsus is going to be new label expansion. There will be competition as well, that they have to bring the price down. And we already know in Europe, Wegovy, Ozempic, same exact drug is
Right.
$150
It's
per
cheap.
month.
It's going to come down. The prices are going to come down.
If they can do it in Europe, they can do it in US. So I think now we're going to think more globally in the pricing and show the outcomes in a better way, and all the other pipelines are going to hit, all this amylin, myostatin, and different ones, more orals, then the companies have to come to an agreement that this is a very common disease, that we need to treat everyone, not just high socioeconomic status. I think, but we will struggle for a year or two, I think.
Or more.
Maybe more.
Okay, what are your views then on compounders that exist? Because they're selling unapproved product, so that sounds scary. It's remarkable. We've never seen anything like this in the history of the drug industry. But the benefit is you're getting drug inpatient, and probably most of the time it's okay. It's a problem also because it takes the physician out of the loop, presumably. So if you're talking what you were talking about earlier, not knowing how to titrate and that sort of thing, it's a problem.
To be honest, of course, we're against something not regulated, but we were expecting more problem with it, but they did interestingly good job. We didn't hear like deaths, we didn't hear like super scandalous side effects. They even partner with Novo, Lilly, they created a system. Actually, they see people sometimes every week, whereas in our center, the next follow-up is because of we are so overwhelmed with months. So I think if you put the regulation there, it's doable through the ingredients, through like generics, through make it cheaper. Even China saying I can bring semaglutide for $20 per month. So I think that we just need to rethink about who can produce this in a regulated manner and how we can implement like worldwide kind of cheaper prices.
Melanie, you mentioned compounded drugs. What's your instinct?
Yeah, I mean, to piggyback on what you were talking about, Caroline, just thinking about all of the ancillary support we provide to patients who are undergoing bariatric surgery and lose 20, 25, 30% of their weight. We now have drugs that are able to do that. And even when we're prescribing them an FDA-approved drug, we still don't provide that ancillary support in terms of nutritional support, psychology support, and that's an FDA-approved drug. And so that kind of support, when you're thinking about compounding pharmacies and compounded drugs, that is nilch.
Yeah.
Well, the federal government contributed to this because they allowed compounding on an emergency basis for a certain period of time, and they got everyone's appetite all up for these compounded drugs. And despite patent protections, they haven't turned off, the allowance of compounding. So I think compounding is here to stay, and will be a competitor until the generic prices come down. And people are just going to get them this way.
For sure. I think didn't the FDA just consider it GRAS generally regarded as safe?
Yeah.
Didn't it just? There you go.
Put on the supplier list.
Okay, so when you're, let's forget compounders for now. When you're deciding between Wegovy and Zepbound, what do you choose? Do you guys prescribe them both? And if so, do certain patients get one and other patients get the other? We know that Zepbound gives you more weight loss. There's a perception that you have better tolerability.
Mean weight loss, and there's a perception that Zepbound has less nausea, vomiting. It does have the constipation. Both sides has the constipation. Zepbound may be more diarrhea, but quite frankly, I like both drugs. The problem with choosing, if you really have a choice, because you don't, right? The insurance companies are now saying one or the other. But if you really have the choice, you don't know who's going to do well on which drug. You just don't right off the bat. So you have to, talk to the patient, figure out, if there's a lot of GERD, if there's a lot of reflux. I stay away from Zepbound. I go for Wegovy. If the patient says I get nauseous at the drop of a hat, then I go for Zepbound. Certainly, if there's a lower BMI range I'm looking at, I'm going to go more for Wegovy than Zepbound. The BMIs over 40 who absolutely do not want to consider bariatric surgery yet, I do go for Zepbound. But the reality is, I have many patients who've been on Wegovy from the get-go, who've been on it now for years, have lost between 40 and 100 pounds and have kept it off. So there's nothing wrong with Wegovy. It's a great drug. And it has the cardiovascular outcomes trial behind it. Certainly, we think Zepbound will end up with that as well. But, it's not 100%.
Well, we have the data. It comes out this week.
Okay,
From
all right, good.
Surpass CVOT. We'll see the results.
That's right. But to know who does, patients who have been on Wegovy and have to switch to Zepbound don't like it, and patients who've been on Zepbound who now have to switch to Wegovy because Caremark is doing that, don't like it. So what are you going to do? It's, the insurers are dictating this.
How, actually, on that front, did you forget?
I was just going to say, I totally agree with Caroline. Also, I think the new thing for keeping the people on is important for maintenance to prevent weight cycling, which is more, problematic than obesity because it increases all the cardiovascular disease itself. So while we try to treat something, we are causing more problem if the people are doing weight cycling and giving this poor access, that tough follow-up program. We know that Zepbound generally more tolerable and it makes it more smooth. Like if you cannot see the patient too frequent, they're having less nausea, vomiting. That makes it easier to follow through, even if you don't maximize the dose. In my own practice, it works a little better than Zepbound, Wegovy. But as Caroline is right, so we started this with lots of people, maximize the dose on Wegovy and did very well. And now it's more payer weigh in and then say, you have to use this one or another. And it created a huge chaos now, I would say, even this summer, which, we know the GIP agonism improves nausea. That's been shown before in animal studies in some cancer patients. So it's an advantage for certain individuals, but that's not a problem for maybe at least 50% of the people that we are treating. So I think we should have the access to both and utilize really case by cases. But now Zepbound has the advantage of more smooth transition and titration, I would say.
How often are you, so CVS a few months back, actually starting July 1, only covers Wegovy, no longer Zepbound. How often are you guys asking for medical exceptions, and how often are those being granted?
We don't have the resources to appeal all of these. We just can't do it. And so we unfortunately, we don't do it. We don't do it. We don't have the resources. We've got, the prior authorization process to get one of these drugs covered under any insurance takes 2 to 6 weeks. So
Again, you're talking about like a marginal gain. Tolerability aside, the marginal gain is not that much compared to the baseline Wegovy or GLP. And so I think when you talk about epidemiology and the treatment for the masses, getting it out with 75% of the effect is better than limiting it with 100% of the effect. And so I think there's going to be a lot of research also, and I agree with Furkan about sort of strategies to keep people on these drugs is going to be just as important as what to start them on. Because if, no matter what you start them on, if you know, X% go off, you know, in 9 months, you know,
Yep.
what's the point of it? So I think getting a drug that's, you know, tolerable for a longer period of time, even if it doesn't work quite as fast, but if it gets to the same place in the long run and you can stay on it, that is a major, major advantage in this era.
Yeah, I'm very concerned about the weight cycling. As Furkan mentioned, weight cycling independent of BMI is independently associated with increased cardiovascular risk and diabetes risk, and in some ways we're iatrogenically creating this by all of the switches that we have to do between Zepbound and Wegovy. And my own patients, once they achieve their weight loss goals, ask if they can stop Zepbound, and this is part of the counseling that I give them, that you lost the weight, but the disease is still present and we take the drug off. It's not a lack of willpower that's resulting in the weight regain, it's the biology of the disease. If the GLP-1 is suppressing your appetite and slowing gastric emptying, and then you take that break off, of course you would gain weight. So I really counsel my patients that they shouldn't just plan to hit their target weight and then go cold turkey. I think that there needs to be more in terms of weight maintenance and long-term maintenance plans.
Yeah, I tell patients, you're on this forever. That they don't ask me, if you put a patient on a hypertensive medication, lisinopril, nobody asks you, how long do I have to stay on this, right? Same thing, this is a disease. You know, I saw patients this morning, and this one patient came in with Blue Cross Massachusetts. I think they're the ones who are saying no AOMs are approved as of January 2026, right?
I don't know,
Yeah.
probably.
Yeah, I think
Possibly.
they've been, you know, so my patients, I have many who've lost 50, as I said, 50 to 100 pounds on Wegovy and Zepbound. What's going to happen to them? They're going to gain all the weight back and maybe have an MI or a stroke or AFib or something, right? Because the weight comes back rapidly if you stop it, right? So are we going to get lawsuits now against Blue Cross because they...
Yeah, I don't know. I mean, it's
you know.
surprising, right?
And I think probably we will talk with the muscle and all. Like, if we do this, people lose muscle, gain fat. Lose muscle, gain fat. And when you think about this, and when they come to us, it's already like 5th, 6th, 10th try to get this going. And we know that this is basically evolutionary biology that, you know, when you lose weight, the brain always wants it back from many different mechanisms. So we clearly know that we cannot go without the medications. So we have to find a way, either protocols, interchangeable protocols, and keep either of the medication. At this point, we really want people to stay on it. And when they're already on high doses, it's relatively easier to switch because they mostly tolerate. So intolerant ones, non-responders is a different category that we need to, maybe more choices. But now we really need to figure this out because it's causing chaos and losing the public kind of trust again because they're very angry. So there are some, you know, trials that we know, but there are also lots of conditions that we cannot just get. Like we have protocols from infertility, we have protocols from neurosurgery, like intracranial hypertension. I have lots of patients, for the first time in their life, their intracranial blood pressure, like the pressure is normal, and they're super happy, and then this insurance tells to change, and they're losing their mind. They're calling the clinic every day. It's like absolute chaos that we really need to find a way. If that's even compounding, we even come to a term that maybe it's even better than the current situation.
Okay, I want to ask, so it sounds like all of you are recommending that patients stay on therapy, but if you look at the data shows that less than half are on therapy at a year mark, and I know there's a lot of cycling off, and there's a lot of confounders, there's been supply limitations, there's coverage issues, as we've talked about, but we all did a call earlier a few months ago with you guys, and I think you said at your centers you're seeing persistence rates that are dramatically higher than the figure I just quoted. Is that correct?
That's correct, but we have obesity treatment centers that specialize. We have doctors, nurse practitioners, physician's assistants, and RDs, registered dietitians, helping us. So the doctor sees the patient, The next appointment is with the RD in a few months, then the nurse practitioner twice over the year, and we also have dietitian-led virtual support groups that meet every other week to help the patient with side effects, with their behavioral, dietary, and exercise goals. This is all important to help the patient manage side effects, learn how to eat so that the side effects are lessened. So it's what you eat also that will produce nausea or less nausea. And the exercise is so important to maintain the muscle mass along with a high-protein diet. So that's, the primary care physicians just don't have these kinds of resources.
Okay, so on that front, sometimes in settings like this, drug companies offer wraparound services where they can help with this sort of thing. Are Lilly and Novo doing that at all?
What was the question?
Are Lilly and Novo offering any sort of wraparound services, supporting practices, supporting patients to try to drive
Well, they would be smart
persistence?
to do that.
It's
I
never
don't know
worked.
if they're doing it. But
It's
I mean, I
never
would just
worked.
add to what Caroline is saying. At MGH, we also have psychologists, and not even nutritionists, but psychologists. And so, in anyone who's in clinical practice knows that if you explain to a patient what the side effects might be before you start a drug, they will expect that it's all a game of expectations, and they won't be surprised, and you have a much better chance. And so the model that we have a much, much higher retention rate than what's quoted in the literature. And I think the problem, as Caroline is saying, is it's not a model that can be brought out to the masses. So I don't know whether it's a matter of education or whether we need training with more APPs that can help in this. But if this is not going to be under the realm of primary care, it's only going to get out to a sliver of the population that needs it. That's the next era.
So what we've talked about to help mitigate this problem is to have a physician's assistant champion at each primary care site who we train in obesity medicine, who can then become that site's go-to person, at least one, to try and bring some of the resources that we know is necessary and that education to the primary care offices. That's the only way this is going to work in the future. Primary cares have to start treating obesity because, it's going to be like hypothyroidism or type 2 diabetes. Primary cares do treat those. These patients don't get sent to the endocrinologist. We can't handle all of that.
But we will have to, I think for pipeline and all the future, we will think about this. So even currently, 75% of the prescribers are from the community setting, GPs, PCPs, community providers, and probably this is going to stay in this way. Like, I think the ideal is more obesity specialists, but it's going to take years to really expand the field in an ideal way. So we have to empower the community practices, and then from a patient side, from the provider side, having maybe daily oral inductions or easier drugs, less side effects. Like, these are going to be important, or less complex injectors, not like dual chambers. Like, we have to think about this, even where to put the pipeline into the paradigm. So because we really changed the paradigm, now we are really treating something was untreatable for many years in a good way. And we know now obesity is not a risk factor. It causes different type of diseases. Like, we work on asthma. We discovered a hormone comes from fat tissue, goes to airways and causes non-allergic asthma, which you cannot treat with classic treatments. Cardiology cannot treat HFpEF with normal diuretics. MASH, fibrosis, we were the top leading cause for liver transplant, but we were not able to treat. So sleep apnea, the first ever approved drug is tirzepatide. And when we look to the pathogenesis, it's a different type of disease happens from obesity, not risk factor. It's like a different type of disease, and we just can't treat as a specialist. That we have to empower the community practices and find more practical drugs, safer and with less side effects.
I'm going to try to make a case for why obesity and its treatment is different than anything else we've encountered. It's different than the treatment of lipidemia, hyperlipidemia with a statin. Why? Because the prevalence of obesity has increased. Why? Not because of our genetics, but because the environment has changed over the past 50 to 100 years. So, this is a brain disease. Our brains are in tune with the environment, and whatever it is in the food supply, we can argue all day long if it's sugar, if it's fat, if it's a combination, if it's a preservative, but something in the food supply has caused the prevalence of obesity to increase. Now we have a disease. We can say it's due to inflammation around the hypothalamus, but in treating it, we have GLP-1s that alter your perception of the environment, the food environment. So you've got to use your brain, and you've got to use lifestyle and your cognitive ability to help that GLP-1 work. That's why it's not just like taking a statin and you can just go about your day. It's very different. That's why this is such a transforming set of medications, life-changing set of medications. That's what people say. I don't hear the food noise anymore. That's life-changing.
So, okay, Furkan, you'd mentioned this, and I wanted to, it kind of builds on the line of questioning I had. And, we have proven data sets, things like sleep apnea, heart attack reduction, better joint health. Anecdotally, where are you seeing these drugs also have an impact? You see it in the media sometimes, addiction, they're being studied for Alzheimer's, but where else are you seeing, even if only by anecdote, the GLP-1s are having an impact?
So I think, even maybe speculative way, that I think GLP-1 alone is going to be like aspirin for primary prevention. I don't know if it's in 10 years, 20 years. I feel like it's going to be over the counter or a simple like drug, especially oral one. People will think about the decreased cardiovascular risk, having heart attack and stroke, because it's a weight-independent effects. We almost fully convinced now. The second, Alzheimer, we knew that if you treat obesity and diabetes in a well, so you improve, and then there is an inflammation in the brain that is causing it. So we are seeing with Alzheimer's is improving in animal models, and from all the association data showing it's going to be most likely successful in Alzheimer's disease. Also, from hypothalamus, there's another higher center, it's called hedonic brain, that tells you to go and eat again. It's like hedonic brain it's the same place that tell you to drink alcohol, get the drug, get the sugar. It's like the same place that has the GLP-1 and GIP-1 receptors. So when you treat, so it also decreases the desire to drink alcohol, your whatever you utilize opioid. Like we see a lot of improvement in alcoholism, addiction already happening in front of us. So we think that it's going to be a good tool for alcohol use disorder. I feel like very immediate because it's already even published from Weight Watchers, like thousands of individuals. I think we can really expand to many different obese-related diseases, which are more than 100, as we know. So we don't have time, I know, going through each. But we prioritize the untreatable and bigger problems. And I think addiction, Alzheimer, alcoholism is among the top that we need to do something. Even opioids, I think.
Yeah, I think also that there's some really interesting emerging work that there are independent effects on inflammation, beyond weight loss, which is maybe why it's potentially therapeutic in Alzheimer's. But like, for example, this cardiovascular effect that is so strong, I mean, is it just because the people have lost weight, or is there something interesting about it at the level that we do a lot of cardiovascular stuff? Is there something interesting about it at the level of the plaque? So I think there are a lot of other interesting studies, even beyond the simple comorbidities that clearly relate to excess weight, like some sleep apnea and stuff like that, which is pretty logical. But this other stuff, I think, is really the next frontier. And the development of co-peptides could be even more interesting in that, because GLP and GIP and amylin all have slightly different effects on these pathways.
I think it's very exciting to think about obesity as a chronic inflammatory disease. And and then open the doors in terms of what other ways could we treat obesity if we think about it as a chronic inflammatory disease. There are some preclinical data that are exciting looking at NLRP3 inhibitors, which is, as we sort of think about NLRP3 inflammasome being activated in obesity and showing that inhibiting NLRP3 can prevent or reverse diet-induced obesity in mice. So I think that this really opens the door for another mechanism of action to treat obesity.
Okay, so on that front, in as much as you have familiarity with some of these mechanisms that are in development, I mean, we have the amylin agonist as kind of the next hot thing that investors are looking at. Lilly has retatrutide, which hits three things, not just two, glucagon being that third target. Your impression, anything really jumping out as promising to you? You had mentioned one that's in something in the earlier stages.
I'm most excited about drug combinations that are combining GLP-1s with some orthogonal mechanism of action outside of the enteropancreatic hormones. So one example of that would be bimagrumab, so the activin myostatin inhibitor, and thinking about how myostatin activin inhibition can be used to maximize fat loss and maintain muscle mass, and the potential positive cardiovascular and cardiometabolic effects of that, because I think there is a limit to how much you can suppress someone's appetite and how much you can slow their gastric emptying. And so, adding on additional enteropancreatic hormones, I think can only get us so far, and then we need to think of another mechanism of action.
Well, like glucagon, for example, has its own independent effects on energy expenditure, independent of appetite. So I think some of these copeptides are really interesting. Also, there's now work combining it with insulin. So to improve your diabetes control, you give the insulin and you prevent the weight gain, you have further weight loss. So the opportunity to add this as an adjunct to even plain GLP to other therapeutics is really interesting as well.
So we probably also think about, amylin is we already utilized, we feel good about it, and we know the mechanism of action is distinct. It improved leptin resistance, which was one of the big problems in pathogenesis. So it was not a druggable target before that is really revolutionized with all the companies. We're very excited. Even it's a GLP-1 intolerant individuals, it's a really good alternative, or for sarcopenic or frailty, elderly individuals, it would be more gentle than GLP-1 with potential cardiovascular benefits. So definitely muscle mass preservation in the game, and most of them is central mechanisms, decreased food intake. At the end of the day, people do not like having no appetite, so then it brings peripheral mechanism of action. So normally all these adipogenic pathways there, normally pushing extra energy into fat tissue is fine, but in a setting of obesity, it becomes pathological, and if you decrease the tone of these adipogenic pathways, like inhibin beta-E, FABP4, GPR75, these are all utilized siRNA technologies or gene silencing, so that gives us potential maintenance or maybe increase the magnitude of the weight loss with the GLP-1s and potentially be utilized every 6 months or something, so that might be in the paradigm. But every aspect on every bucket in obesity treatment have millions in it, so we need to think about it. So cardiovascular risks are important for glucagon, that increased sympathetic tone that we would be worried about, or for myostatin inhibition. So there are different side effects that we are just facing now with if we inhibit everything there, like activin A, myostatin, and GDF8, 11, all of them. So I think we will kind of see which one is safer, and I think combination therapies are not going to be paid by insurance. I think whatever the new drug, it has to be a one compound, so the solubilizing in neutral pH is going to be important to make it one, like antibody backbone with GLP on it or something like that. I think so with the companies are going to be more creative also to get the regulatory approval, because that's also not very clear for muscle mass preservation or other combinations, that what it means to have additions. So I think with this, we think that the GLP will stay as a standard of care, and it has huge cardiovascular benefits, GIP, GLP as well, but the rest is going to be for more of the case basis and then the classification basis.
We're going to wrap it up. We're a little over time, so thank you, Caroline, Furkan, Steve, and Melanie. This has been a great session. Thank you, everyone, for attending.